liver. Yeah, ours is a liver transplant center, and that is the largest center of the West India, uh, of the West India. So we are having a more of a liver transplant intervention, and a majority of our work is gastro intervention, onco, as well as liver transplant. Where I was in training, we have much work of the, we had major work of the vascular intervention. So everywhere spectrum changes where you work. So I'll start with the liver intervention. The first case is 42-year male patient who has undergone liver donor, living donor liver transplant. And the protocol is like after transplant, they do the color Doppler twice a day for at least 5 to 7 days. And immediately they sometimes find the hepatic artery thrombosis. For that is the only purpose. And usually they find portal vein or as well as hepatic vein, any issue is there. And as early as you identify, the better the outcome if you intervene earliest. So this was detected on the sonography, and sonography was also slightly tricky in post-transplant cases. So you have to just identify the anatomically where is the hepatic artery. You will never see on grayscale whether artery is there or not. You can only identify on the spectrum. So once you put a spectrum, you won't be able to identify any arterial waveform. Then you detect that it is the arterial, some issue is going on, and then they do the CT scan. Unfortunately, I don't have the CT scan, but we directly took for the angiography as early as possible. This is the first angiogram that we took from the celiac trunk, and if you can see, there is a complete cutoff from the anastomotic site. So this is usually a 10 to 20% of the post-transplant cases, we can identify this kind of occlusion as well as sometimes stenosis. The most common complication post-liver transplant is biliary complication. It is around 30 to 40% cases. Portal vein as well as hepatic vein complications are relatively rare. Second most common is hepatic arterial complication that we are seeing here. So once you identify the angiogram, and then you have to identify where is the pathway. So if you have CT scan, like that is before the procedure, or if you have anatomical course of the hepatic artery, that would be the ideal thing. But here we don't know where we should go inside the liver. So sometimes we ask the surgeon that how they have anastomosed, like right side or left side sometimes, or sometimes more internal. So according to that, we identify that we should put a wire. And first we have to take the support of the guide catheter. So Judkins right catheter, that is like cardiac people are routinely using. So we create the triaxial system, that is micro catheter, diagnostic catheter, and Judkins right catheter. Put our Terumo wire inside the GDA, and we get the proper location from where we should intervene. So this is the Terumo wire going into the GDA. Then we over this we put a support catheter. And once we identify everything, then we put the micro catheter and micro wire. So in post-transplant cases, you have always crossed the lesion with the micro wire, and that is soft micro wire without any loop. It should go straight only, because with loop, it will create the dissection. And dissection is very common in post-transplant cases at the anastomotic site. So we usually use the run-through wire, that is coronary wire. And along with that micro catheter, that is 2 French or 2.4 French. We try to go according to anastomosis, like blindly. We don't know where our wire is going. So once our wire goes inside, and we just give the screwing movement, if you see here in the first image, we just try to push the wire in the true straight tip, and then we just screw it, and sometimes we feel it that it is in the lumen. So once you are inside, then you put the micro catheter. Even if it goes outside, there is no worry. So this is the trial and error method to cross the hepatic artery occlusion. So once you confirm that you are in the true lumen, then we change the run-through wire with the V14 wire to get the support. Then we do the plastic. This is the plastic with the 2 mm balloon. Usually you don't need to put larger balloon. This is just to get the stent across the segment. And then we inserted the, this is the post plastic. And now you get the landing zone. But here, if you can see, there is a large thrombus at the anastomotic site. So this we tried with thrombus, but we are not able to remove this thing. And you can't take your guide catheter or larger catheter here, because it will dissect the artery and it will create more issue. So we put the bare metal stent, balloon expandable coronary stent, across the anastomosis. That is 2.75 diameter, and I think 20 mm or 22 mm. So this is the stent deployed. But after that, still there is a proximal thrombus. So we put another that is covered stent, graft master, to extend the proximal aspect, so that thrombus part should not get directly touch into the blood vessel. And this is the our graft master that we have extended proximally. And if you can see, this is the final result. 1 minute. Yeah. So this is the final result. Now here there is a issue. If anyone can identify. In this last image, there is one issue.
So there is a proportionality of the parent vessel and this appears to be.
Yeah. So there is a, yeah. So distal vessel is around 3 mm. We have put the stent of 2.75. So ideally it should be around 3 mm. But now we don't have that option. Another one is the first vessel that is arising after the anastomosis is posterior branch. Here they usually take the right lobe. So we have anterior and posterior. This is the anterior branch and this one is the posterior one. So that is occluded. That is gelled actually, not occluded, but that is gelled. And usually these cases, they will get occluded over the time. Once you cross the stent across the anterior and posterior bifurcation, so we should be more careful that it should not cover up. Anyway, but the post procedure, this is the Doppler study, and that is showing good anterior systolic upstroke in the anterior branch. However, posterior branch, there is a filling from the collateral. If you can see, I don't have that post check angiogram also, that is filled from the anterior circulation, and that some collaterals are filling the posterior branch. So this is the why we have put a stent. Sometimes people are asking that in acute thrombosis you should not put the stent, but we learned it from coronary people. Like cardiologists, they are acute coronary syndrome, they are putting the stent everywhere. So this is the best way we can reperfuse the ischemic liver. And another thing to remember is whenever you do the liver transplant intervention, the hepatic artery is more important artery. Portal vein is important, but in native, you say that 80% is portal, 20% in hepatic. But post-transplant hepatic is more important because it will create a biliary ischemia immediately. If patient is remain ischemic for at least 24 hours to 48 hours, then they will develop the future biliary strictures as well as bile leak. Anastomosis won't heal. Biliary anastomosis won't heal. So portal vein flow is important, but hepatic artery is as important as portal vein. So now we'll go to the another intervention in the post-transplant, that is living donor liver transplant and anastomotic bile leak. So this may happen with the intraoperative technique as well as sometimes biliary ischemia also, like arterial stenosis, or as well as sometimes arterial caliber is small, like last images you have seen. So that can lead to bile leak at the anastomotic site. Usually they do the ERCP, that is always a first intervention, and they try to put the stent in the anterior or posterior as per anastomosis during the intra transplantation. So now once you have bile leak, that is very difficult to identify the biliary duct because it's usually collapsed. So there are two techniques. Once you just take a central puncture. Here we were able to puncture the peripheral under ultrasound guidance. This is a posterior duct, that is segment, I think segment 7 duct. And then we identify but you see here, there is continuous bile leak. So it hardly remains for 3 to 5 seconds. So within 3 to 5 seconds, you have to puncture this biliary duct. So first we punctured and we are not able to put the wire. So we thought that we'll put another Chiba needle and we'll try to target this area. But that was also not successful. But after 2 hours of attempt, we are able to put a wire from the upper needle. That is our primary needle. So this is the wire. And here we are using the run through also. Same wire we are using, coronary wire. Then we took the NAP set dilator, and then we took the micro catheter and micro wire to cross it. Here our wire is in the leak. This is the leak, bile leak, and our wire is there to get the support, or at least to get up to the proximal part. Now our wire, we are trying to go into the CBD. This is the biliary stent that is placed via ERCP, but they were able to put only in the anterior segment. Posterior segments were not able to cannulate. So now our wire is going inside the CBD. So it took almost 30 minutes to get this access. And once you are inside the CBD, then there is very easy to exchange it with the internal external catheter. Now, what happens in the future? So this is actually very rewarding thing, because over the time that bile leak will heal once you put the stent across the leak. And after three months, they usually do it internalized. So via ERCP, they put the stent after 3 months, and that will be kept for at least 9 to 12 months. And change every 3 months. So bile leak will heal once you put a stent, because healing will process around that tube, and bile leak will heal. So this is another second biliary intervention. The third one is the hepatic venous. So usually they sometimes augment the vein by using the venous graft or artificial graft. So here it was identified on the USG Doppler that they find out the congestion in the segment 8. So right hepatic vein was normal. Middle hepatic vein is there is some congestion, and there is a stenosis at the anastomotic side. This is the right hepatic vein. It is going very well. But if you see the middle hepatic vein, we are not able to access from the above. This is from the middle. If we try to access from middle hepatic vein from the above, it was not possible because of significant kink is there at that level. So we punctured the hepatic vein percutaneously, and it goes inside very easily. This was the kink. If you can see, contrast staining is also there, and then it goes inside. So we snare from the above. This is the snaring from the above. So we get the through and through access. This angiogram. Here you can see definitely there is a good cutoff at the anastomotic side, at the hepatic vein and IVC anastomosis. So actually it was a kink only rather than occlusion. So after that we identify the landmark and we put a stent across that area. So here we put the stent. We have not dilated the percutaneous tract. So it was only with the Chiba needle and inner dilator of the that needle, because that will take the 1,4 wire. So that's why we have done the through implant from the above. So after that congestion resolved and patient did well. Now another one that is relatively a new indication. It's outside of IFU, but we have got a very good result with almost 6 cases that we have done. All in young patient. This is 39-year male patient with mesenteric venous ischemia. He was treated outside with heparin for 5 days, but patient has worsening liver function as well as persistent abdominal pain, mild ascites, and tenderness. So INR is also deranged, platelet deranged, elevated lactate, liver enzymes are also significantly higher. So he came in the emergency and we did the emergency thrombectomy, pharmacomechanical thrombectomy. CT scan suggestive of SMV as well as SMV has a complete thrombosis. So we did the percutaneous access of the portal vein. And it was relatively easy with the Chiba needle or micropuncture. Those two are our, always we are using a Chiba needle or micropuncture needle for any access. So once you are inside, then we took the angiogram. It is suggestive of complete occlusion of the SMV. Portal vein was partially open, but this is the splenic vein, and this is the inferior mesenteric vein, and this is the SMV. Then we use the angiojet, that is 6 French compatible with continuous alteplase infusion with the pulse spray mode. And along the full SMV, we have injected the alteplase, that is around 10 mg, diluted with around, I think, 100 ml or 50 ml. And then after angiojet, we waited for 30 minutes. And this was the after angiojet images. Still there was a thrombus, so that we aspirated with the angiojet. This was the excellent result post aspiration with the angiojet. And then we close the track with the glue. So we are not using coil for the track closure. We are using only glue, 50% diluted glue, along with the dilator and sheath. And I have follow-up CT scan also. This is the follow-up CT scan. Here, if you can see, portal vein is completely open. This is the SMV. splenic vein, SMV. If you see these images, there is hardly any evidence of mesenteric venous thrombosis. This was done for another indication because he has already developed a venous infarct. So he has undergone the laparotomy also, but the resected segment was very low and patient came out afterwards. So now the discussion is always going on for mesenteric venous thrombosis. What is the best option or best access site? What you can feel and what we are doing, I'll tell you. So in young patient, we are like hesitant to put a stent or to do the tips. So via tips route. But in case of CLD, it's a definitive. You should do the tips via tips route and do the mechanical thrombectomy or pharmacomechanical thrombectomy. But without CLD, any mesenteric venous thrombosis, you can do with the portal access as well as splenic access. We have done one case through the splenic access and majority cases with the portal access. And as peripheral as possible, you puncture the portal vein, either right or left, and then you recanalize the main portal and SMV as well as opposite portal vein. That is either left or right portal vein. You have to insert the 6 French angiojet catheter and try to establish the outflow. So that is the advantage of tips route. But in young cases, in young patients, we are hesitant to put a stent. Now, what you are practicing, you can share experience. Sir. Hello?
Yes, sir. We can hear you.
Yeah. So, any difference, sir, opinion?
I think still larger part of the larger majority of cases that come are generally managed conservatively on anticoagulation initially, unless there is significant bowel changes. So I think my experience in this is also limited because the number of referrals for the same indication where intervention has been done is very few only. But generally, still we prefer to be on the conservative line unless, as you said, bowel infarct, venous congestion is not a primary issue.
So, yes, sir. Our gastroenterologists are slightly more pro for intervention, sir. So, in young cases, we are more pro, but the only thing is persistent pain despite heparin, tenderness, and ascites. These three things we are usually seeing within 12 to 24 hours. If it is worsening or it is not improving, then we directly go for intervention if patient is affording. So, we have got excellent results, sir. Almost 6 or 7 cases with angiojet for mesenteric venous thrombosis we have done, and I think all has recovered very well with good functional outcome. Some two patients required laparotomy, otherwise they are doing good. And over the time also they will develop the, if you don't reopen, they will develop the portal hypertension, and there's some issue of the long-term varicose bleeding also. So best is to establish the native flow. That is what our gastroenterologists prefer. So that's why they are more pro for intervention. So this is another similar case. If you can see the CT scan, there is a almost 90% occlusion of the SMV and portal vein. I am running again. This is the main portal vein, and SMV is occluded. And this is the pharmacomechanical that I did, the same protocol. And this is the follow-up CT scan. If you can see, there is no evidence of any thrombosis. And this is the Doppler reports that suggest that complete recanalization of the MPV with wall-to-wall flow. So we are having an excellent result, sir. Now, another case, that is a 59-year-old male patient who is diagnosed with HCC moderately differentiated. It's a biopsy proven, ECOG 0B and child score A5. Approximately 12 centimeter size lesion is there with arterial phase enhancement and portal phase out. Portal phase was out. So we took it for chemoembolization, and our protocol is when large lesion is there, we are using depth test. If lesion is smaller than 5 centimeter, we are using lipiodol test. When we are doing the second session of the test after any depth test or any issues, then we are usually doing the lipiodol test to see the retention of the lipiodol. So first session we had done from the hepatic artery, and if you can see, there is a large arterial feeders, multiple arterial feeders that we embolized. We have got the excellent necrosis of the tumor with almost, I think, 80% necrosis with 20% viable tumor. And on CT scan, we identify the another feeder, that is inferior phrenic artery. And we did the second session of the test from the inferior phrenic artery. Now, after this, patient has some pleural effusion as well as breathing difficulty. And there is some literature that says that DEP test is harmful when you do with the extrahepatic collateral. But we asked a few seniors also, and they are telling that it's okay to do, but just explain that pleural effusion may develop and respiratory difficulty will stay for at least 1 month. But another thing is this anatomy was very difficult. So we have to order the Shepherd Hook catheter from the Mumbai. It was not available in Ahmedabad. You might remember that Shepherd Hook catheter is like slightly upward curve. It is nearly similar to the SIM one, but the shorter primary curve. So that was we are able to cannulate the inferior phrenic. After that, the second follow-up CT scan that is suggestive of almost 5% to 7% viable tumor. And now we identify the feeder from the internal memory as well as left gastric. So we embolize both internal memory and left gastric. This was the third session for the DEP test. And after that, this is the final, just recently done 1 month before. If you can see, it remains stable. Although there is a viable tumor that is less than 5%, but it remains stable in the size. So we have not gone any further intervention. But we got excellent result. This lesion was stable since 1.5 years. So a DEP test can be done to extrahepatic collaterals, but be vigilant for the complication, especially when you do the phrenic artery. And large tumor, we experience that DEP test has better drug delivery as compared to lipiodol test. Now there is another one where I got a call in the middle of the night that patient is having a acute limb ischemia. If you can see, he is having a brachial bifurcation, acute thrombosis, and patient is having some prothrombotic condition, undiagnosed, and he has a cerebral venous sinus thrombosis and PE. He has stopped warfarin for 3 days, and he immediately developed this kind of thrombosis. Pulse was not there. CT suggestive of bifurcation occlusion. So I did the angiogram with the 7 French long 90 centimeter long sheath, that is from Aero, that I took and put in the subclavian artery and took the angiogram. There is a bifurcation thrombus at the brachial artery. Here you can see. Then I took the aspiration catheter. That is longest catheter available in my cath lab was React catheter. That is around 145 centimeter long, because I don't have other catheter to reach this thrombus. So it's always useful to see your armamentarium, because at that time, if it was not available, I was in trouble in the middle of the night. So that's why then I aspirated it. I aspirated good amount of clot, and then post procedure there is a sluggish flow in the radial artery, but I let it go, and patient is having a good saturation, and pulse SpO2 came 100% in the finger. So I kept him on heparin, and warfarin started next day. So aspiration works when you have the landmark. So what I learned is, if you have a landmark, that is a proximal brachial artery is seen, distal brachial artery is seen, and if you do the wide bore aspiration, it usually works, or at the bifurcation level. But you don't have distal landmark, only proximal occlusion or cutoff is seen, and you are aspirating, it may not work, because I have tried it in the another cases in the lower limb ischemia. So when you have a landmark from distal normal and proximal normal in between thrombus, then better you can start with the aspiration with large bore guide catheter or aspiration catheter. Now another case, that is 46-year female, diabetes, hypertensive. She has a past history of thyroid surgery, and papers were not available, but at that time she developed the vocal cord palsy. Then again she is planning for surgery, and surgeon explained the risk of repeat thyroid surgery, that is laryngeal nerve injury and permanent tracheostomy, and goiter has some retrosternal extension. So we explained her, this was the first case that we did in Gujarat for thyroid artery embolization. So we explained her that we can do this procedure, but results we were also not sure, but there is no harm. So we embolized the superior thyroid artery, that is left superior thyroid artery. after embolization, pre-embolization, along with the PVA particle. This is the right superior. So the concern is only cosmetic concern as well as mild tracheal compression. So she had left inferior thyroid is already ligated during the last surgery. Right inferior, we left it because completely all four or all three thyroid arteries should not be occluded. So we left one thyroid artery pattern and two artery we embolized with the PVA particle. And this was the just 15 days follow-up. She came and we took a plain CT scan to just compare the pre-procedure and post-procedure. And we got good reduction on the left side. Right side, not significant reduction, but it was just only the 15 days. And if you can see the external appearance, the thyroid has been reduced significantly. Another case, just similar case. Here we can see right lobe thyroid swelling. We embolized it with PVA particle. And this is a 6 months follow-up we have, and almost completely reduction of the neck swelling. So over the time, we have done almost 10 cases of the thyroid artery embolization. So what we learned is that embospheres are better than PVA particle because of a larger amount you can deposit in the thyroid artery. Second thing is thyroid after embolization, patient will have significant pain. So it's a painful thing. Sometimes thyroiditis may happen. So we usually keep the endocrinologist along with us in case of any issue. Thyroid hormone related, and we have treated one Graves disease also, that is Graves hyperthyroidism, and patient became at least patient was having a reduction in the dose of the anti-thyroid medicine. So then another one out of the book indication is parathyroid adenoma ablation. So we have done almost 25 cases of thyroid nodule ablation, that is benign thyroid nodule ablation, and we got excellent result. Then parathyroid adenoma, we have done the first case here. So patient is not fit for surgery or patient is not willing for surgery. The surgery is still a first choice for parathyroid adenoma. But when it is not possible or patient is not willing for surgery, then we can do the ablation. Here you can see parathyroid adenoma is slightly posterior along the thyroid capsule and just adjacent to the common carotid artery. So we did the confirmation with the scintigraphy scan. Parathyroid was 391.4 before the procedure. First, I went from the thyroid isthmus and I targeted the parathyroid adenoma, but I was not able to completely ablate it. So I came again. I came again from the opposite side. This is the hydrodissection. This is a parathyroid adenoma, common carotid, posterior to the parathyroid adenoma. I injected the fluid. And once, okay. And then I came again from the lateral aspect. This is my needle. So here we have to ablate fully. Parathyroid adenoma, we can't leave any part because it will again secrete the parathyroid hormone. So in thyroid, you can leave the capsule or any danger area that is around the vocal cord. But in parathyroid, we have to ablate fully. And once you ablate it, parathyroid become normal within 24 hours. This is the second day more immediate post procedure. After 2 hours, we send parathyroid hormone, and second day within 24 hours, it became normal. Now another case that I learned from the Chitra Institute during my training, that is a long segment SFA occlusion and SFA stenosis. If you can see, SFA is completely occluded up to P1 segment, P2, P3 pattern with single vessel runoff. This is the ATA runoff. So we have to establish the inline flow as patient is having a gangrene. So we tried from the upper, from the antegrade aspect, but we are not successful. Then we came from the retrograde aspect. Even single vessel outflow was there, we are able to puncture the ATA because ATA caliber was significantly larger. And after that, we did the safari technique as well after balloon, and then we are able to pass the wire. So still we are not able to cross the directly to the seat. So we snare the wire from the above, cross over seat. This is the snaring from the above, from ankle puncture, we inserted the wire and then we access from the snare. Then we deploy the supera stent and we got the excellent result. Good inline flow. We have done the puncture slightly higher level as we were usually doing at the ankle level. So then we thought that we insert the balloon and we inflate the balloon for 3 minutes. And this is the post balloon. There is still some leak was there, but that was compressed manually. And then we stopped. And we got excellent result. Now another one is aortoiliac occlusion. This CT scan was 1 year old. So I thought it's okay. So we have a good landing zone. Only thing is renal artery may compromise because IMA is just arising at the occlusion level. But within 1 year, that extension has been increased and it reached up to the external iliac artery. Just origin of the common femoral, it was extended. That I know before the procedure because ultrasound, I was able to ensure that I had got a landing zone of around 4 to 5 centimeter. But during puncture, it was much difficult than I anticipated. So we took the angio from we have standard protocol to take the 3 axes, that is brachial axis and both femoral axis for aortoiliac CTO. For stenosis, you can do with the 1 or 2 axes, but for CTO, you have to ideally do the 3 axes because it will give you the idea where you get the true lumen from the above. So here, renal artery is just at the origin of the occlusion. This is the inferior mesenteric artery and SMA. So distally, if you can see, I took the puncture with the micro wire and then dilator I was trying to put, but it was not going inside much. So then I took the terumo wire and I tried to insert the sheath up to this area. Here, if you can see, landing zone is around the acetabular rim. So this was the distal most landing zone I ever encountered in these cases. We have done aortoiliac almost 6-7 cases, but almost all landing zone are in the common iliac artery or at least proximal external iliac. But here landing zone is at the external iliac and common femoral junction. But then we go ahead because patient doesn't want any kind of surgery. So we have to do the endovascular intervention. And we came above from the above. So we always try first from the above. If it is going downside, that is the best thing because there is no risk of extending the dissection at the cranially. And we directly entered the sheath from the left side. So for this case, I specially ordered the 4 centimeter sheath. If you are aware of, I don't know, but Merit has 4 centimeter 6 French sheath. So that is length is only 4 centimeter. That may be the pediatric sheath. So it will stay up to here only. And from above, we are able to cross the CTO. So now over the time, we learned that for aortoiliac CTO, you should directly try with the H1 catheter as well as straight tip terumo. So if you use straight tip terumo, it will drill very well and it will go through the true lumen. So from both sides, we are able to cross from the above. And then we did the angioplasty, kissing angioplasty as well as external iliac angioplasty. So here I put the 7 mm stent that is first in the external iliac and common iliac artery because I want to confirm that distal landing zone should be covered. So for up to the acetabular rim, I deploy the stent. First I put the distal stent. Usually the protocol is you usually put the proximal stent. And other cases that we have done aortoiliac, I used to do bifurcation Y stenting. That is 114 mm stent inside the aorta and 2 7 mm stent in the common iliac artery. But here I was not sure whether I should cross again after putting the 14 mm stent. And landing is slightly longer because with that also 3 stents will not be able to finish. So then I have to put the 5 stent. So I let it go that idea and I put the 2 extended stent, 7 mm stent. So here it's a 14 mm. So this is the proximal stenting. Here if you are able to see, this is the landing zone. So this is the angiogram and renal was patterned. So I have just kept the wire in case renal compromise. I will put a stent there also, but it was okay. So I was not worried about it. And during the removal of the sheath, I just tried to extend the sheath with the 7 French. And at that time, my stent strut came in the sheath. So here, if you can see that stent strut is distorted. I tried to put a balloon there at this level. This is our sheath tip, and this is the sheath entry, if you can see. So this was one of the most difficult access. But after that, we put the pro glide here on the right side, and then left side we compress manually. So what do you think that what is the best option in this case, as patient is not doesn't want any surgery? If I was not able to access the femoral, hello, would you go ahead with the SFA puncture, or would you try to put a 6 French sheath in the ATA and try to cover it up from the below? Because in this smoker cases, infrapopliteal vessels are usually good. So would you try to get access from the PTA and do the intervention, or you try to puncture the SFA just at the origin and then do the case?
I think SFA is an option. Brachial can also be the upper limb access, and you propose a brachial one or a radial.
Okay.
Was it a radial or a brachial?
No, brachial, sir. We are doing the brachial only.
Even I think that there was still, I think, around 2 to 3 centimeters of SFA bilaterally.
Yes. Yeah. So
Not
SFA you do
SFA,
puncture.
not SFA, CFA. So
So
the initial that femoral head, that entire length is available for you for puncture.
yes.
That would be probably the primary option personally for me also.
Okay. And SFA you use this closer devices, sir, or only CFA only?
Actually, Proglide I don't think be safe unless it's that good size and SFA away from bifurcation. Even your angioceal, the problem is if there is a bifurcation, the paddle may get stuck at the level of that bifurcation where profunda rises. So that paddle might itself cause occlusion. So if it is possible, generally, personally, I would still prefer a manual compression.
Okay, sir. And another one, sir, that aorta you do Y stenting or only kissing stenting, sir?
For extension into aorta, you are telling?
Yeah. So aorta larger 14 mm.
Yeah, simultaneous deployment from above till below.
Okay.
Usually, I
No,
think
what I was
covered. This you have put bare metal, no?
Yeah, bare metal only.
Yeah.
So
Okay.
what I was asking is, I previously where I have done the aortoiliac cases, I used to put 6 centimeter long or 4 centimeter long 14 mm stent in the infrarenal aorta, and then do the two kissing stent of 7 mm in the both common areas. So in this case, I have not done that thing.
Yeah, generally, whatever cases that has been done recently here, we are putting just 2 stents as parallelly. Commonly, that will be there in the aorta. The other one is technically a bit more time consuming, and the aortic diameter also, the stent availability also needs to be assessed. No?
Yes.
So, gently double barrel parallelly, you will place from aorta into each of the iliacs. But again, the personal choice is what you do.
I thought it was more physiological, sir. That's why we used that larger one at the infrarenal aorta and two smaller one in the iliac. Anyway, that okay. So I think this is another one that I did recently. That is paroxysmal nocturnal hemoglobinuria. And patient has thrombotic tendency. Patient presented with acute Budd-Chiari syndrome with acute onset abdominal pain and with ascites. So this is the CT scan. If you can see, liver is classical nutmeg liver with peripheral significant congestion. Caudate lobe enlargement. And there is some thrombus extension in the IVC. And ascites was there. So we did the DIPS procedure for this case. There is a hepatic venous stump was seen. So we punctured it and we are able to puncture the posterior branch of the portal vein, right portal vein. And we have placed the covered stent. So this is the entry puncture site. That is a branch portal vein. And this is the parenchymal tract. This is a eye covered stent, balloon expandable covered stent. And here we are able to assure that that both stenosis are covered. This is the proximal, this is the distal one. Both are covered. Then we have put the long bare metal stent. So here my question is whether we should cover the covered stent up to the parenchymal tract only, or if a branch portal vein is punctured, so we should cover the this covered stent up to here. That is 2 centimeter more proximal. So in this case, yeah. So here I put a covered stent up to this length only, but this is the portal vein, branch portal vein, but there is no parenchymal tract here. So should I extend this parenchymal tract, this covered stent up to this area, main portal vein, because here diameter is around 10 mm, but this diameter is around 6-7 mm. So it will remain like that only. So if you see the last image, so here if you can see, this is the 10 mm because we have put the dilated this thing. This one remains 7 mm because it is a self-extend. This is the 10. So should I cover this covered stent up to this level, or only parenchymal tract is enough? That's why I kept this scheme, and that flow remains pattern. Patient has been prescribed eculizumab. That is the drug of choice for PNH. Sir, any comments, sir?
I'm also not sure.
Because what I learned is only parenchymal tract covering is enough. But after looking this image, I thought that I should have taken the covered stent up to this level and
Yeah.
then bare metal up to this level.
Yeah.
I don't know, because sometimes you may be able to puncture the peripheral portal vein. Then what to do?
Okay. A difficult decision to make. We'll see.
Okay, sir. So that remain pattern. Sir, do we have time or?
How? Yeah, time is there around that.
Oh,
10 minutes more. So 1 or 2
yeah,
more.
sir. Yeah, yes. So this is a 59-year female patient who is having a distal pancreatectomy 1 year back and then presented with melanine HB doc. CT suggestive of large pseudoaneurysm from celiac trunk. However, celiac anatomy is favorable. Patient is having accessory right hepatic artery, native right hepatic artery from main hepatic artery and celiac trunk, and left hepatic artery and left gastric directly from aorta. So this is the most favorable anatomy I encountered in these pathological cases. So this is the first angiogram. That is from the, this is the GDA, this is the right hepatic artery, and this is the pseudoaneurysm from the celiac trunk. Here is the pseudoaneurysm, GDA, celiac trunk. This is the left hepatic. Upper one is the left hepatic artery, and this is the left gastric also going from that area. So I confirm that this is the GDA, right hepatic. So I occluded the celiac trunk with the coil, with good packing of the coil up to the celiac ostium. I have not planned for covered stent because there is no harm in doing this thing. And this is the left, if you can see, this is the left hepatic artery, left gastric artery. Both are sealed. That is coming directly from the aorta. And this is the accessory right hepatic artery. And this is our GDA retrograde filling of the right hepatic artery. So there is no harm in doing the occlusion of the celiac trunk. Okay. So this is another case that I have not treated, but I kept it here for discussion purpose. So female 38 years old. She has undergone some ultrasound abdomen for some mild abdominal pain or discomfort. And she is detected to have pancreaticoduodenal arcade aneurysm along with MALS. She is not having any weight loss, not having any significant abdominal pain. So she has undergone CT scan, and this is the axial CT scan. This is the Mal's origin. I will show you sagittal also. And pancreaticoduodenal, multiple aneurysms are there. This is the first aneurysm. This is running again. Here is the aneurysm. And one more is here. This is the another one. So two aneurysms are there. Those both are in the pancreaticoduodenal artery, along with celiac axis stenosis. This is the coronal image. One aneurysm. Another one. This is sagittal one. So here, Mal's was there. So what is the treatment option? What should I do? The largest side of the aneurysm is 12 mm, and the aneurysms are true aneurysm. Those are flow related aneurysm. So what is the treatment option? I have not treated till now. I'm planning to treat this case now. Sir, any input, sir?
Again, as you said, I think because it's true aneurysm and size criteria is still around, the largest being only 12. I think, and additionally, there are multiple also. So I think presently direct treatment